Assalamu alaikum wa rahmatullah. I am Dr. Mohamed Mahmoud, Assistant Teacher of Obstetric and Gynecology, and I am talking with you about cardiac disease with pregnancy problem. In this problem, we are going to talk about history, examination, and investigation. The history of this patient, aged 32 years old, she's gravid 5, para 2, living 2, abortion 2, normal vaginal delivery. She is 32 weeks plus 5 days, low socioeconomic status with history of administration of long-acting penicillin till the age of 18 years for rheumatic carditis. So he mentioned it's cardiac patient. There was no history of chest pain, respiratory distress at rest, but it appeared on exertion. I am going to explain what this paragraph mean. Not known a case of bronchial asthma, diabetes mellitus, hypertension, complaining of dyspnea on exertion, just complaining of dyspnea on exertion. General examination, the patient is conscious, oriented, afebrile, thin built, normal gait weight, weight is 60 kg, height is 162 cm, no pallor, icterus, edema, cyanosis, clubbing, pulse rate is 100 per minute, good volume, regular, blood pressure 110 over 80 millimeter mercury, respiratory rate 16 cycle per minute. Neck veins were not enlarged, no engorged leg veins. Obstetric examination, fundal level 32 weeks. It's like the period of amenorrhea, 32 weeks. No uterine contractions was noted. Okay, cephalic presentation. Okay. Investigations, ultrasound on pregnancy show single living viable fetus with adequate liquor and fetal movement. Okay. Echolog show mild mitral stenosis, just mild mitral stenosis, and the double tricuspid valve lesion, V, mild stenosis and regurg with good systolic function. Okay. What is the management and the management during labor? Okay. Mention management during pregnancy and the management during labor. Mention to other investigations could be done. Okay. At first, we have to talk about classification of heart disease with pregnancy. Grade 1 mean no symptoms. Grade 2 symptomatic with heavy work. It mean dyspnea on exertion, no manifestation at rest. So our patient is grade 2. This was I was talking about. Grade 3 mean symptomatic with less than ordinary work. Grade 4 symptomatic at rest. Even at rest, she is dyspneic. Management during a pregnancy. Okay, I put this item to remind you to talk about the preconceptional care, proper management of chronic tonsillitis and rheumatic fever. Okay, during a pregnancy, I have medical care. I made that like a scheme to be easy remembered. Avoid anxiety, bed rest, no smoking. 3. Treat 3 things: treat anemia, treat infection, treat hypertension. Okay. Decrease salt, decrease weight, TT. Prophylactic diuretics, prophylactic digitalis. Okay, to avoid heart failure during pregnancy. Obstetric management during pregnancy. Maternal monitoring, double the frequency visits. The normal visits is from the beginning of pregnancy up to 28 weeks, just one visit per month. From 28 weeks to 36 weeks, if the visit is every 2 weeks. From the beginning of 36 or the beginning of the 9th month, every week until delivery. So in cardiac patient, double this visits. Fetal monitoring in the third trimester. Because this patient in the third trimester, we have to do fetal well-being test, and you will take it in details. Okay. Hospitalization at critical period from 28 weeks and 30 weeks. 30 weeks maximum increase in the blood volume. So this period is critical and need hospitalization for the patient. During labor, normal vaginal delivery. Normal vaginal delivery is the rule in heart disease with pregnancy due to small fetus, soft cervix from pelvic congestion, or maybe due to systemic congestion. Precautions during delivery: prophylaxis from endocarditis by amoxicillin 2 gram IV, gentamicin 80 mg IV at onset of labor or before CS, followed by amoxicillin 500 mg oral or IM or IV every 6 hours. Positioning: semi-sitting position or left lateral position. Analgesics: Bethadine or morphia to avoid pain, because pain lead to reflex tachycardia and more load on the heart. Fluid restriction and oxygen mask. Second stage: no bearing down. Shorten the second stage by forceps and or ventouse. Okay, this is items. You have to know the mechanism of delivery is 50% bearing down, 50% uterine contraction. In cardiac patient, we are afraid of bearing down to avoid the hypertension, okay, and overload on the heart. So no bearing down, and we replace it by forceps or ventouse, external suction. Okay, third stage: guard against postpartum hemorrhage by oxytocin, no misogyne as it produce hypertension. Postpartum diuretics to avoid heart failure. Postpartum care: bed rest for 2 to 3 weeks with leg exercise to avoid DVT. Breastfeeding is allowed unless there is heart failure. Prophylactic antibiotics to guard against infection. The contraceptive advice to the cardiac patient: TS, it means tubal sterilization, ligation of both tubes of completed hair family or heart failure. Okay. Mechanical with spermicidal, it is the first choice. Mechanical contraception or spermicidal gel is the first choice. Progesterone only pills, injectable and non-plant for lactating women. IUD is contraindicated due to high risk of infection. COC or combined oral contraceptive pills is contraindicated because the estrogen may salty water retention and more hypertension and load on the heart. The second question was mentioned to other investigations like CBC, BT, INR, ECG. Advice against pregnancy in the following condition: class 3, class 4 heart disease, heart failure in previous pregnancy, pulmonary hypertension, severe mitral stenosis. We mentioned in our case it was mild mitral stenosis, ischemic heart disease, cardiomyopathy. All these cases are contraindicated to get pregnant. All of the following could be given postpartum to the cardiac patient except: number 1, prophylactic antibiotics. Yes, we can give the patient prophylactic antibiotics. Metformin IV after delivery of placenta. Metformin is ergometrine that produce hypertension, so we have to move to the next one. Oxytocin IV after delivery of the placenta. Yes, to guard against postpartum hemorrhage. Diuretics could be given, yes, to guard against heart failure by preventing volume overload from returning of the placental circulation to the maternal circulation, placental blood to the maternal circulation. So our answer will be Metformin IV after delivery of placenta. Metformin is contraindicated in cardiac patient and asthmatic patient, okay, because it produces contraction of smooth muscle, of blood vessels and bronchi or the bronchial tree. Thank you.